So I was asked to talk about metastatic disease, and ironically, in this same course, a long, long time ago, I was also asked to talk about metastatic disease. So this is a slide. I think this is close to the 25th anniversary of EPCOT, but I wanted to talk about METs. So I think everybody thinks they know about METs, and I thought I knew about METs. And what really changed my mind about what I didn't know about METs was actually looking at something called the literature as opposed to what I was taught. So I'm hoping that there's things in this talk that you're going to learn the same way that I learned, and you're going to be just as skeptical when I mention them as I was when I first heard them. So we're going to talk about how METs are common. We're going to talk about the cascade and the seed and soil theory. How many of you have heard of the seed and soil theory? Okay. How many of you have heard of the cascade scheme? Okay, good. We'll talk about single versus multiple lesions. We'll talk about how the location of METs is variable and how the presentation can be variable, and that allows metastatic disease to mimic other lesions, and you've seen some examples of that already. So let's talk about common. How many of you think that METs are more common than primary brain tumors? Okay, so everybody does. So short story, I had been at the AFIP for 2 years, so this is 1987, 88, and I told everybody that primary tumors are twice as common as METs, and after I recovered from the vegetables being thrown my way, there were 2 residents from Wilford Hall that said, that can't be true. And I said, what are you going to do? And I said, well, we're going to go back to our hospital, tertiary care hospital, and we're going to go through all of our records electronically of all the patients that had neoplasms. And 2 years later, they called me up and they said, no, primary tumors are twice as common as METs. Okay, that's what they came up with. So was that right? I don't know. We'll have to talk about that. So people talk about metastatic disease being 11.1 per 100,000 in the US. Primary tumors are variously reported as being 12 to 14 per 100,000 per year, depending upon the series you look at. Most path series show primary are more common. So let me just say that again. Most pathology series show that primary tumors are more common than metastatic disease. Immediate disclaimer, well, that's because you got pathology. That's because you got pathology. You knew it was a MET, so you didn't get tissue. So it's just a bias to the pathologist. So that's a common argument that people make. But wait, there's more. About 15 to 25% of cancer patients will develop brain METs. That's actually probably an overestimate, and we'll see some better numbers in just a second. 9 to 10% of cancer patients will have METs only in the brain. They won't have liver, lung, and bone METs. So that's a little bit different than what I expected. 1/3 of patients with METs will be asymptomatic, 2/3 will be symptomatic, so you can find incidental METs in asymptomatic patients. I want to make a comment about the patient being symptomatic. I don't have any symptoms of metastatic disease today. I don't have any CNS symptoms today, but I might have them tomorrow. So if you scanned me today, I would be in the box that's called asymptomatic, and if you scanned me tomorrow, I would be in the box that's called symptomatic. So the only way to get good information is to do a population-based study where you're getting everybody in a population of patients, not just the people who are symptomatic. And also, if you're thinking about doing functional MR screening, there are papers that report 10, 15,000 patients who were volunteers for functional MR, and they get screened before they become a normal volunteer to make sure that they're normal. And if they're symptomatic, they're not normal, and they don't get into those studies. By the way, those studies show that primary tumors are more common than metastatic disease, just to go into that. So some treatment protocols require screening of the brain as part of the initial staging. So neurologic symptoms, we talked about that. They can have seizures. They may present with seizures. Typically, if you have more METs, you have more seizures. You don't get seizures with posterior fossa METs because that's not where the motor cortex is. So this is an old graph from Levin, a great oncology book, and this is the 1997 edition, and they showed that primary tumors are twice as common as METs. But then all of a sudden, something went off, and a light bulb went off, and all of the standard oncology books say something like this. Metastatic metastatic disease, these are rented lips, metastatic disease are 2 to 10 times more common than primary brain tumors. You find that in almost every standard oncology book. And it's not referenced. There's no citation next to it, so you can go back to the primary source. So that's another potential problem. So Mets are 2 to 10 times more common than primary tumors. That's what we see all the time. And then here's this other guy. Okay, but my book here says something different, so that's the devil. And my job today is to be a little bit of the devil's advocate to go over which one of these two perspectives is correct. So this is from 2016. From the Gray Journal. It's not exactly a third-tier journal. It's our premier journal, Prevalence, Clinical Management, a Natural Course of Incidental Findings on Brain MR. So they're using MR, and it's a population-based study. A little bit less than 6,000 patients, 5,800 patients, clearly adult patients. So another bias that comes in is people say that kids are more likely to have primary tumors than Mets. Adults are more likely to have Mets than primary tumors. And again, what did they find? 2.5% of the patients had meningiomas. That's a brain tumor, right? Isn't meningioma a brain tumor? 2.5% had meningiomas. 2.3% had aneurysms. By the way, those numbers are in the same range as what the pathologists have been telling us for 70 or 80 years. So if you say there's something screwy going on, how would it skew things for the pathologist and imaging at the same time unless you're getting closer to the truth? So we'll have to think about that. This is a beautiful graph. And this is a graph of the actual number of patients, 143 for meningiomas, 134 for aneurysms, a whole bunch of other things. There's this lonely one patient out of almost 6,000 that had metastatic disease. And here is possible glioma without histologic confirmation, 6 patients. So you could look at this graph and you could say, okay, gliomas are 6 times more common than metastatic disease in an unselected patient population. And that wouldn't be correct because this isn't the way that you answer that question. You have to have the histology and everything else and follow the patients up. But have you guys have heard of something called regression towards the mean? Regression towards the mean means when you measure something over and over again, you eventually get closer to the actual correct value. And so if your initial value is that Mets are 10 times more common than primary tumors, and you measure it over and over and over again, you should get closer to the real value. The value might be 12 and not 10, but the value might also be 2, or the value might be less than that. So we have to worry about that as well. So here's a study looking only at patients who had cancer, and they had 8.5%, not 25%, they had 8.5% of the patients over a long period of observation developed metastatic disease. It was a mixture of different kinds of cancer. We know that some cancers are more likely to metastasize than others. So you see where I'm going with all of this? Everything we know may not actually be correct. The standard argument that I get is there's 70,000 cases of lung cancer every year. 50% of those people are going to get brain mets. That number is 4 times larger than the number of all primary tumors. And my answer to that is, that's a great calculation, but that's not research. You haven't measured something, you have calculated it, and if all of your variables are wrong, the calculation is going to give you the wrong answer. So, but let's talk about Mets. So, whatever you think is the baseline, 1/3 to 1/2 of adult brain tumors, people predicted that there would be a rising incidence of Mets because of longer survival from the primary tumor and because of improved detection by CT and MR, and also because we typically talk about Mets in adult patients, not in children. One of my friends who's really smart was listening to me argue, or discuss rather, with a colleague about what's more common. And he came up to me afterwards and he said, Jim, you're telling your friend that Mets are more common than primary tumors because we now see them because we have more sensitive imaging. Isn't it likely that you would also see more primary tumors with more sensitive imaging? And isn't that the actual observation that we've made, that we see more primary tumors? We see more of everything, especially if you're talking about MR with gadolinium. So let's talk about the cascade and the seed and soil theory. So how do we get CNS metastasis? Local invasion or extension from head and neck neoplasms, perineural spread. Those adenoid cystic carcinomas are actually sometimes called salivary gland type tumors that spread along the nerve. Sometimes they're from the salivary glands, but sometimes they're not from the salivary glands. So the lacrimal gland tumors are also salivary gland type histology. Lymphatic spread is uncommon because there's no lymphatics in the brain, but there are lymphatics in the dura. And hematogenous dissemination is the one that we talk all the time. Just kind of an interesting point. We saw great examples of pelvic Mets today in one of the lectures. Pelvic primary tumors are notorious for metastasizing to the posterior fossa. You heard a discussion earlier today that since the hemispheres are 80% of the volume of the neural tissue and the posterior fossa is only 10 to 15%, that we should expect that mimic in the ratio of where Mets go, hematogenous dissemination. But pelvic malignancies can give you a solitary metastasis in the posterior fossa because valvulus Batson's plexus allow the tumor emboli to go up along the paravertebral plexus and get into the posterior fossa. So that's something, if you see a solitary lesion in the posterior fossa and you're thinking it might be a Met, but then you talk yourself out of it because that's the only lesion and there should be 4 upstairs if there's 1 downstairs, remind yourself about pelvic malignancies. So they're distributed by blood flow where the filtration is. When vessels caliber changes, where there's angular branching, the tumor emboli are going to park. And we, little cartoons of how that works. They just kind of park where the vessels taper and branch. And typically that's near the gray-white matter junction. But this patient with metastatic melanoma also reminds us that you can get these little tiny 3 millimeter, 2 millimeter Mets in the basal ganglia, and they get there through those perforating vessels. So I always say, 100% of the time, I'm going to say subcortical, 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 maybe cortical. I'm always going to forget the deep gray matter. So you can get Mets in the deep gray matter, and that's a great example of it right here. Okay. So in terms of the cascade theory, GI malignancy, where's the filtration bed? We were talking during the morning break that the purpose of the lungs is just to catch crud before it gets into the systemic circulation, before it gets into the brain, so it gets clots and tumor emboli as well. So if you have a GI malignancy, portal veins filtered in the liver. If you get liver Mets, then you can get systemic Mets by going through the lung circulation. The systemic lesions, and after it gets to the lungs, you can filter out things. So theoretically, it's hard to prove it, theoretically, you don't get systemic tumor emboli unless you've had it come from the lung. It's not 100% like that. We know that you can have pathologically nothing in the lungs and have systemic dissemination, but typically there should be something in the lungs. So to get brain Mets, you might have liver Mets, then lung Mets. If the patient has a right to left shunt, then you can bypass the filtration bed in the pulmonary circulation. 20% of us have a functionally patent foramen ovale. What does that mean? I didn't take my Metamucil this morning. I'm straining at stool in the bathroom, and I'm shunting a little bit of blood so I can get that systemic embolization. And then I mentioned Batson's plexus before for pelvic malignancies. So what protects the brain? One of the things that protects the brain is the blood-brain barrier. People have suggested that those tight junctions in the continuous basement membrane protect the brain from getting tumor embolization. But the other thing about the brain is it is a hospitable environment for some lesions. Melanoma happens to be one of those lesions. And why is that? Well, melanoma is a neural crest tumor. The brain is related to the neural crest. So if a tumor cell gets up there, it's like, hey, this is great. They're giving me some fertilizer here. I'm going to grow. So example here, you have renal cell carcinoma. You get a pulmonary metastasis from that. And then you end up going into the right atrium, right ventricle. And if you have, then it goes out into the pulmonary circulation. It gets into the pulmonary veins, left atrium, left ventricle, and then it becomes systemic. But if you have any kind of a short circuit, it's going to bypass the pulmonary filtration bed. So if you hear people talking about the cascade theory, this is what they're talking about. There should be this logical progression of Mets. And of course, they're going to become larger over time in this patient. So multiple lesions, we think about metastatic disease. We want to talk about the seed and the soil theory. So, you have one of these dandelions that's in that puffy phase and you blow it out. Does every single one of those things take root and take hold? No, just in my yard, okay? So in my yard, those things are all over the place. It's like my grandson's blowing on them. I said, please, Jack, don't do that. Why? Because then I'm going to have them all over the place. But, the notion is that you have the primary tumor. A lot of tumors arise from epithelium, whether it's gut, pulmonary, or the skin epithelium, because those cells turn over all the time. It generates a blood supply. Solid tumors that are larger than 2 or 3 millimeters have to have their own blood supply because the limit of tissue diffusion for oxygen and glucose is just a couple of millimeters. So the primary focus is like a breast carcinoma. You get a 3 millimeter breast carcinoma. It has a blood supply. That's how we see them on gadolinium enhanced MR of the breast. So it has all the enzymes, metalloproteinases to digest into the adjacent vessel walls. It has VEGF to stimulate its own neovascularity. Then the tumor cells get into the circulation. Then somehow they lodge and get out of the circulation. And then the distant focus, the metastasis, ends up generating its own blood supply. That's basically this cascade notion that we talk about. And this is supposed to happen in every single metastatic lesion, that you have this process. It gets to a certain size, it has its own vascularity, it invades the vessels, it gets into the circulation, those circulating cells manage to get filtered or parked, they get out of the vessel, then they have to stimulate their own circulation distally. So this seed and soil theory actually came from the English surgeon Stephen Paget, and he said that the microenvironment has to be suitable for the growth of these dislodged tumor cells. And that's the prevailing theory that we like to think about for the seed and soil. So let's talk about single versus multiple. And there are very few people who will stand up in front of you and tell you that primary tumors are more common than Mets. And fortunately for me, I'm bold enough to tell you that, but you all have my email address. So please, send me the correct answer so that I stop spreading this black pearl in medicine for the rest of my natural life. But one of the things that I read when I was looking at the literature from the apocalyptic people that say that primary tumors are more common is this notion about singularity versus multiplicity. And the M's go together. Metastatic disease is multiple. But the pathologist used to tell us that at autopsy, that they would see 40 to 60% of the patients who had metastatic disease had a single lesion. Have you ever gone to brain cutting? You go to brain cutting and they cut slabs that are about a centimeter and a half thick. So they only see things that are on the surface of that slice. It's like slicing raisin bread. If you want to count the amount of raisins in raisin bread, you can't just count the ones that you see on the edge of the slice. You have to count the ones that are in the middle of the slice that aren't on the surface. So we passed off in the early days of CT, said the pathologists are wrong. We're seeing them on CT because we can see a 3 millimeter enhancing subcortical nodule, and the pathologists don't count them. But in actual fact, that ratio of multiple to single is the same for pathologists as it is for us, and it stays the same when you slice thinner and thinner and thinner because you see more small primary things as well as seeing more metastatic lesions. It's still in that range of 40 to 60. But this is the difference. And the difference is you see that one metastasis, and then hiding behind that one metastasis is a whole army of other lesions that are going to show up over time if the patient survives with that initial lesion. So the notion we have is that somebody comes in, the brain is screened as part of their workup and evaluation and staging, and we might not see anything, and then they come back 6 months later and they have 20 lesions, and all you remember is they had multiple lesions. You don't remember that first time that you scanned them and they didn't have a lesion. So we know that there are going to be more of them. There certainly aren't going to be less of them over time, unless they have really effective adjuvant systemic therapy. But, I can make the point that solitary lesions occur, but I can't prove the demographics of the prevalence of solitary lesions. So I can go into the teaching file and I can find this case here with a single lesion. I can tell you the literature shows that the ratio of multiple to single is still in that same range of 40 to 60%. I can tell you that when you increase the sensitivity for Mets, you increase the sensitivity for primary tumors, but you're not going to believe me unless you look at the literature yourself, and you may not take time to do that. But lots and lots of cases of solitary Mets, which we don't really pay attention to because our bread and butter is working with the oncologists and following up their patients and seeing how their patients do over time. But lots of solitary mets. It is not hard, and we've all seen cases of solitary metastatic disease, and we know that they will come back with more lesions later on, and we'll remember that they have multiple lesions. So, when we're teaching trainees, we teach them that mets are multiple. We want to remind them that a solitary lesion might still be a met. Now, something to think about, if you have a solitary lesion like Harpert showed you that's in the deep white matter, that's more likely to be primary than a subcortical smaller nodular lesion that's more likely to be a metastasis, because that's where mets get distributed. But, there's other criteria that he told us about. So multifocal lesions, by the way, this is one where I really screwed up. I thought this patient was an IV drug abuser, and these are multiple abscesses. And then they introduced me to the admiral's wife, and they said that she was on systemic therapy for a metastatic breast cancer. And so these all became rapidly necrotic because the systemic therapy was working. So this mistake I won't make again. But anyway, multiple lesions. Look where they are, by the way. Did I mention basal ganglia to you? And look at the thalamus. So you'll get them in those locations. You'll get them in those locations. So what else is hematogenous? What else is going to give you multiple lesions? Hematogenous dissemination is all kinds of things. We'll talk about that. Vasculitis and demyelination is multifocal. Trauma is multifocal. If you have a systemic predisposition to making a neoplasm, that's typically going to be multifocal. Toxic and metabolic disorders are multifocal. Environmental exposures are multifocal. There's multifocal glioma and multifocal CNS lymphoma, primary CNS lymphoma. So anything that's hematogenous, Mets, abscess, infarcts can give you multiple lesions. So what does this patient have? This patient has cysticercosis, neurocysticercosis, multiple lesions, very cute because you can see the scolex sitting in each one of these fluid-filled spaces. By the way, are these also in the basal ganglia? Do you see the lesions there in the caudate nucleus? Do you see the lesion there in the thalamus? So we always say subcortical, subcortical, subcortical. It's basically where the gray matter is, and you have the right caliber of vessels to be trapping those systemically embolized particles, whether they're larvae or whether they're bland clots or infected clots. But you can also have multifocal primary tumors, CNS lymphoma, as we also heard earlier today. Those lesions, they can be ring lesions, they can be homogeneous lesions, but they can be multiple. That's one of the things we look for. The distribution of multiple lesions in primary CNS lymphoma tends to be in the periventricular area, not in the subcortical area. And the multifocal lymphoma tends to be more diffuse and fuzzy looking, and so they have a different kind of appearance than what you would see if you had a subcortical metastasis. And multifocal glioma, we know that glioma cells, diffuse gliomas by that descriptive term, are diffusely infiltrating into the brain, and they can spread along the white matter tracts, and they can set up housekeeping with neovascularity in different locations. And so, maybe 15% of diffuse gliomas are going to be multifocal. And then you have the genetic neoplasm. So, primary CNS lymphoma, periventricular, funny-looking rims. Those rims don't look smooth and round. We also have a lower signal on the T2 weighted image, and that's from the hypercellularity, which we heard about earlier from Harpert's talk. So yeah, this is pretty typical and classic for primary CNS lymphoma. By the way, 5 out of 6 cases of intracranial lymphoma are primary, and they're usually parenchymal, and the other 1 of 6 cases of intracranial lymphoma are from a systemic lymphoma, and that's usually extraaxial. So those are real patterns and real observations that have been validated over time. So we want to keep that in mind. This is a multifocal glioblastoma multiforme. So, this doesn't look too different from that previous lesion, and this one's even just slightly lower in signal on the T2 weighted image, and these heterogeneous ring-enhancing lesions, path-proven multifocal GBM. How does that happen? Well, the tumor gets into the white matter, and the pathologist will tell you that if they examine the corpus callosum, they might not actually find any tumor cells, but sometimes if they look really hard, they can see isolated tumor cells creeping along the white matter. And that's because those tumor cells, someone came up to me once, I was in the Netherlands, and someone said, Jim, are you trying to tell us that these neoplastic glial cells have amoeboid activity and that they get into the white matter and they crawl through the white matter and then they go someplace else? Do you expect us to believe that? And I said, well, yeah, I do. And they said, why would you expect us to believe that? I said, well, because it's true, number one. And number two, we can actually measure the speed at which these neoplastic glial cells spread through the white matter. And number two, there's two different phases of glial cells in a diffuse neoplasm, especially glioblastoma multiforme. There is a mesenchymal phase where they have this amoeboid activity. And then there's a proneuronal or proneural phase. And what drives them to go from the proneural phase, where they sit there and proliferate into that necrotic ring lesion, and trips them into infiltrating through the rest of the brain, is hypoxia. The same hypoxia that causes the central necrosis stimulates a genetic change in the tumor to begin creeping away from the ischemic area to then spread through the rest of the brain. Anyway, multifocal genetic, patient with NF2, bilateral vestibular schwannoma is a trigeminal schwannoma. So again, the distribution, as we talked about, is primarily by the blood flow. So let's talk about a couple of other things. So just very briefly, scalp, skull, dura, subarachnoid, parenchyma, choroid plexus, pituitary pineal, that's where we can have them. We've seen some mets in the skull, so I'll just show you a couple here. Calvarial metastasis show up on your neuroimaging. A nice kind of bulgy one here. Lytic lesions, lytic lesion there. The cortex is gone. Lytic lesion in the diploic space. We can have blastic metastasis in the spine, like we see here. There's a laundry list. I was taught there were only two things that were sclerotic metastasis, and that was prostate and treated lymphoma. And it's like everything else. My list gets longer every year. Next year, if you tell me peanut allergy causes blastic mets, I'll have to add that to the slide. But prostate and breast and lymphoma, and also some of the neuroendocrine tumors can give you these blastic metastatic deposits. So that's something to keep in mind. So some nice blastic metastasis there. 75-year-old man with urinary retention. I think that's every 75-year-old man. So that's not really a telling history. But why is there no vasogenic edema? We heard about that also earlier today. It says, why is there no vasogenic edema? Because these are all extraaxial. This is metastatic prostate cancer, and these are all extraaxial. There's still a little bit of dura around these lesions. So that's why we don't have any vasogenic edema for this. So that's going to happen. It is possible for one person to have both prostate cancer and breast cancer, but usually you picked one gender or the other, and you only get one of those or the other. It's probably a bad comment to make, but metastatic neuroendocrine tumor, again here separated from the brain by the dura. That dark line around the lesion is where the dura is. Metastatic neuroblastoma, we're all familiar with how we get this hair on in. We think about that being a primary bone tumor for that. Multiple bone but no brain mets, so they show up there. We have dural mets. Dural mets are most commonly from prostate, breast, and lymphoma. This is metastatic. This is metastatic, basically secondary CNS lymphoma. This was an interesting one because what do you think they thought it was when they first saw this? It's a meningioma, right? It has a dural tail, it's convex towards the brain, it's extraaxial. They did an angiogram, so it blushed. It didn't blush exactly the way the textbook flavor of meningioma blushes. There wasn't a central feeding artery, there wasn't a spoke wheel vascularity to it, but they still weren't really sure. They went and you see this creamy white thing that is just under the dura, that's not a meningioma. Meningiomas typically are going to be reddish tumors. And by the way, Harper told you a really important thing for the surgeons. If the tumor it looks like it's going to be a hard tumor, it's going to be harder for them to resect. So look at that T2 signal, the very important dural lymphoma. Subarachnoid, what the pathologist calls Zuckerguss, sugar icing, where you have dissemination through the neuraxis. We very commonly screen the entire neuraxis. If we see the intracranial lesion touching the ependema or touching the pia, then we'll ask for the patient to have the total spinal access with gadolinium because they want to know if there's CSF seeding before they start the systemic therapy. So you have all this seeding in the subarachnoid space. And then here you have it even worse seeding. This is what it looks like pathologically, all of these blue cells from metastatic medulloblastoma in the subarachnoid space everywhere. And then the last couple of things, choroid plexus. Choroid plexus tumors are more common in children. If you see one in an adult, you could have a meningioma in the choroid plexus in the trigone of the lateral ventricle, but if you see one in the posterior fossa, choroid plexus papillomas in adults are uncommon. Choroid plexus papillomas in the fourth ventricle are even more uncommon. Think about it being metastatic disease. But this is metastatic disease just to the choroid plexus. It's hypervascular. You can see there's tumor here on the other side, tumor here in the choroid plexus. Here's one in the posterior fossa. Renal cell carcinoma loves to do this, by the way, to get into the choroid plexus in the posterior fossa. Renal cell carcinoma here, and then the last thing is the pituitary has no blood-brain barrier, the pineal has no blood-brain barrier. Did I mention to you that the blood-brain barrier might prevent METs from happening because of the tight junctions and continuous basement membrane? So here's a patient that has a lump in the pituitary, which might be a pituitary adenoma. The same patient has a lump back here in the pineal gland. Okay, so the patient has pituitary adenoma and has a germ cell tumor of the pineal gland. No, this was metastatic breast cancer for this patient. So I hope that you heard some things that were new and different, and I hope that you're skeptical and you'll look things up and get back to me. Thank you all very, very much for your kind attention.